Morning and welcome to this meeting of the Board of Directors of Lincolnshire Partnership NHS Foundation Trust. My name is Kevin Lockyer and I'm the Trust Chair. We'll get straight into the agenda. I don't think we've got any apologies for absence this morning. And I haven't been notified of any declarations of interest that are different to those already recorded. So we'll move on then, if I may, to the minute of the last meeting, which was held on 27th of July. Does anybody have any comments on those meetings, either on points of accuracy or on matters arising? I can get the words out in the right order. Don't see any. Are colleagues content for me to sign those minutes as an accurate record? Fabulous, thank you very much. We'll move on then to item 1.4, which is the schedule of actions. There are a couple which are still in progress. And the status of those is clear and as recorded in the paper. Does anyone have any comments or questions about that schedule of actions? I don't see any, so we'll move on then to Chair's remarks. I have got into the habit of trying to keep these as brief as possible, largely because I'm keen to avoid talking about things for the sake of talking about them, and there's always a bit of overlap with the Chief Executive's report, so I tend to try to let the Chief Executive's report carry most of the weight of kind of current affairs, as it were. The only thing I want to say is about the Lucy Letby case, and just to record in public, as it were, the fact that we need, as a board, in fact, around the Letby case, and our approach to that is going to be to get relevant subcommittees to do a bit of a thorough piece of work around the aspects that are relevant to them, both in terms of kind of process, culture and all the rest of it, and then bring that back to board. So it's a piece of work that we do properly and that we understand what, if any, implications there are for LPFT as a trust. So I just wanted to mention on the record, as it were, that that's a piece of work that we have in hand. I know that the Chief Executive's report touches on it too. That's the only thing I wanted to add by way of remarks from the Chair, as it were. So let's move on, if we may, to the Chief Executive's report. Sarah.
Thank you, Kevin. Hello, everybody. I'm Sarah Connery, Chief Executive here at the Trust. So in the usual way, I'll talk through some high-level national, regional and local issues, and then, of course, happy to take any comments or questions. So at the top of the report, just to point out, we are still undergoing industrial action. We're planning now for next week's action in terms of junior doctors and consultant strikes, and I just want to take the opportunity to thank everybody, not only who's been involved in the planning, but during the actual industrial action, as well as pulling us back on the days following as well. So it does feel like a bit of a constant process at the minute. So I just wanted to say a big thank you for everybody for pulling together to minimise the impact on patient care as much as is practically possible. I'd also like to just extend that out to all of our staff at the minute. We are seeing some increasing demand and complexity in terms of our patient presentations, and people are doing their best under some very difficult circumstances. So I just wanted to make sure that was noted. In terms of the Lucy Letby case, as you mentioned, Kevin, included within the papers is a letter from NHS England voicing its commitment to ensuring that lessons are learned and asking boards to assure themselves on the Trust's freedom to speak up processes. And just to point out, it's Freedom to Speak Up month next October, so we have got some events planned to try and push out, make sure people are all aware of the Freedom to Speak Up process, feel comfortable to do so and have a positive experience as a result of it. Of course, our reflection so far within the Trust and the system is this isn't just about the Freedom to Speak Up process. Of course, this is about creating a psychologically safe culture where people can really focus on learning lessons from when things go wrong and be able to talk about them rather than creating safety theatre. So I think there's a lot for us to do as an organisation in this space. Incredibly difficult to read about the case itself, but we are committed to make sure that such things do not happen within our own organisation, with our own health and care system. And on that, we had a really positive inspirational leadership programme event around just culture, and I've included some more information on that in the report, but there were certainly a lot of learning in the room. So this was for all of our Band 7 leaders and above, about having deep and honest conversations, about understanding the impact when there's an incident, what support do people need, whose role is it to meet that need. So we've got a number of actions going forward, but this is the start of our journey, I think, around taking that forward in line with our refresh strategy about having a just and restorative culture throughout Lincolnshire Partnership. Just want to point out the suicide prevention strategy. Hopefully people have seen that be released. Really welcome some of the focus within that strategy, which is a 5-year cross-sector strategy. Certainly within the Lincolnshire system as well, we approach our suicide prevention in a really systematic way. We work really closely with public health and with the VCSE sector. So on the back of this strategy, we are refreshing our system suicide prevention approach, but also with an LPFT as well. So the board will be hearing more about that in the future. And really keen that we've got autism as a focus, given the high rates of suicide for autistic people in the population. So more on that to come. In terms of celebrating success, I just want to point out that I haven't included it in the report, which was remiss of me given the timing, but as well as those that's listed there in the report, we had our Francis Willis Unit patients nominated for a Service User Awards in the National Service User Awards, and they got to attend a celebration event over in the West Midlands. I believe Di, one of our non-executive directors, was able to attend that event as well. We weren't successful, unfortunately, in terms of winning, but great celebration event on the ward. And our service users were absolutely part of organising the event and running the day. So well done to Francis Willis Unit for that. So I'll stop there, Kevin. There's obviously more in the report, but I will assume the rest is as read. I just wanted to point out those bits, and I'm happy to take any comments or questions.
Thanks very much, Sarah. Are there any questions for Sarah? Tim.
Thanks, Kevin. So Tim Harry, non-exec director. As ever, Sarah, thanks for the report. A lot in there. I just really wanted to make two comments and really emphasise one point. I thought the inspirational leader event around just culture was a fantastic event, and I'm going to talk about training and leadership and development later, and I'll sort of pick up on that. I think one of the takeaways for me, sort of underpinning that, was around, you know, we have policies and procedures, and they assume that the system is perfect, and no system is perfect because it's complex, because it involves people, and therefore how we respond to things when they deviate from that sort of system and the procedure and so on needs to be taken in that context. So that was one of the things I took away, as long as all the points that you made. The other thing really was around the freedom to speak up, and it's just I just wanted to reinforce what I raised at the last meeting, which was a report around the deep dive on EDI that we had at the People Committee. And one of the things around there was that clearly there were challenges around cultural barriers to accessing the freedom to speak up. And I just wanted to emphasize that's really an area I think we really got to sort of work on. So those were the two comments, but thank you.
Thank you, Tim.
Thanks very much, Tim. I think there are some wider issues about ED&I there that we'll pick up in private session later today. So thank you for that. Di.
Thanks, Kevin. Di Bailey, one of the non-exec directors. Sarah, I just wanted to ask, under section 2 of your report, where you talk about the regional developments and in particular the mental health oversight group, I was just interested to understand how that sort of gets fed into the system, and where, if any, is there any NED non-exec contribution or oversight to that?
Yeah, good question. It's not sort of seen as part of the assurance process. It's not sort of bolted into any governance process, but it is a way for senior leaders across the Midlands from Mental Health Trust to connect and benchmark where we are on performance. So I have spoken to Mark about using some of that information in terms of benchmarking in our performance committee going forward, right, so that we're not looking at our data in isolation between our own data point. It's in the lens of where are we as a region, and of course you could spread that out nationally as well, but particularly with our East Midlands colleagues as well, you know, with some of the similar demographics. I think it's really interesting that we have that lens. But myself and Girish sort of trying to tend on from the ICB as well, and it's just a really great forum to be able to raise. We're really struggling with this. You know, is anybody else having the same issues as much as it is as looking at performance? And we have a national and regional update as well from NHS England. So it's a really, from my point of view, it's a really great meeting. But we need to make most of it in terms of LPFT performance reporting.
Okay, that's great, Sarah. Thank you.
Thank you.
Thanks, Di. I just wanted to add one thing about Let Be, Sarah, if I may, going back to my remarks earlier, and that is that one of the reasons that we're taking this through committees before we bring it back to board is that we're determined not just to answer the questions that NHS England have asked us in their letter.
Absolutely, absolutely.
You know, thank you.
Thank you.
Thanks, Sarah. Thank you very much for characteristically helpful and a thorough report. I'm really grateful. Thank you. Let's move on then to, if colleagues are happy, to item 2.2, Board Assurance Framework and Risk Register. Jenna.
Good morning, everybody. I'm Jenna Davis and I'm the Director of Corporate Governance at LPFT. So the BAF, it has been redeveloped, and there are new risks which are aligned to our new strategy. And we've got a new template which aims to simplify the BAF to make it easier. There is still improvement work to be undertaken, not only on the BAF, but our risk management systems and processes as a whole. So there is further development and further refinement of the BAF moving forward. The highest risk currently on our BAF relates to our people, and the People Committee have been focused on receiving assurance against the Trust's people plan, with a number of assurance papers together with a number of deep dives over the last couple of months. The BAF risk in relation to quality has been reviewed by our Quality Committee in months, and the Quality Committee have asked the Executive to go away and consider how we can gain further assurance, especially in terms of independent assurance both internally and externally. And I've also requested that the executive ensure that the BAF is up to date with the assurances that we've already received as an organisation. And so that will be reflected for the committee moving forward. And I'm happy to take any questions on the BAF processes.
Thanks, Jenna. A quick comment from me first before I see whether or not colleagues want to comment, and that is that the format is, you know, a huge improvement on what we've had in the past. It's clear, it's you know, well focused. There's obviously still some work to do on, you know, some of the detail, which, you know, probably isn't quite there yet, but in terms of an overall approach, I think it's absolutely you know, moving in the right direction, and I'm really grateful for that. So, but I see that other colleagues have got comments or questions, so I'll start with Di.
Thanks, Kevin. Di Bailey, non-exec director. Jenna, thank you. As you said already, we looked at this as part of the last quality committee meeting, and I think it really took our conversations in that meeting to a much more focused level around risk and mitigations around that. So really supportive of it. Couple of things from me. I think there's a comment in there somewhere about our quality improvement approach being inconsistent in the way that it complies with national standards, and I think just to sort of reassure that we've had some conversations about that at quality committee, and we have been assured that the work that we are doing about our quality improvement we are sticking with, because we believe that whilst there may be a question around consistency with what's going on nationally, actually in terms of what we're doing it probably exceeds it in some ways. So I just wanted to add that. And then there was just one point of accuracy, because I noticed in the assurances, I think it talks about the freedom to speak up report going to quality committee, and actually it goes to people and to audit. Happy for it to come to quality if we see that as a way for going forward, but I just thought I ought to raise that. Thank you.
Thanks, Di. Mark.
Hi, good morning, everyone. So I'm Mark Platts, I'm the Director of Finance, Digital and Estates. I just wanted to note, if I could, a slight point of accuracy on page 23 of the report. It's within the gaps and controls from our financial position. So it does talk about an underlying recurrent deficit of 1 million. Unfortunately, I have missed that. It is actually 4.1 million. Now, this is something that the Sustainability Committee are looking at every meeting in terms of understanding how we can mitigate that and reduce that down to be more of a break-even position should we get to the point of recruiting to all the staff that we have budgeted for. So just wanted to note that point of accuracy. Thank you.
Thanks, Mark. And I'm sure that's comments well received. I think that, as I said at the beginning, we need to iron out some of the kind of detailed niggles in this, but as a general format, it is, you know, significantly better and clearer, and as colleagues have commented in chat, you know, a much easier to use approach. Sarah.
Thank you. Hi, Sarah Connery, Chief Executive. So I just want to reiterate that, because you can start to feel now, can't you, our trust strategy sort of coming alive really, and focusing our conversations within that framework. So a massive thank you, Jenna. I just wanted to respond about the sort of second and third line defence around quality, because I was a bit surprised not to see our accreditations that we do sort of invest quite heavily in. And in fact, we've had the conversation as an executive team around, do we consider as part of cost improvements not investing in sort of third party accreditations like ACOMS and RPSI. But, you know, we were of the belief actually that external view is worth the investment. So I think that would be helpful to answer that question from the Quality Committee. Thank you.
I'm sure that's right. Thanks, Sarah. Sharon.
Thank you. I'm Sharon Harvey, Director of Nursing and Quality. I just wanted to add a bit more assurance around the quality element of the BAF, and I know, Jenna, we're working up some of the other detail as Sarah's just mentioned, but in relation to the patient voice element and how we have wider patient and carer involvement in our assurance process and care, as Lucy mentioned in the board story earlier, we've just agreed, and just agreed with patient participation group yesterday, that we will pilot a freedom to speak up type role for hearing the voice and responding to the voice of patients, service users, families and carers. So we'll see that as an additional line of defence and assurance. And also we want to test some other new approaches, and I'd be really keen for those new approaches to be part of that third line defence, but from a lived experience perspective, to come and provide additional assurances. So just wanted to add that in. And also I think we might have had a bit of point of clarification around the QI comment. I think you meant QIA, Jenna, is that right? In the first bit, Jenna's nodding. So I think we've been QIA processes that we need to improve. So just wanted to clarify that. Thank you, Chair.
Thanks, Sharon. Tim.
Thanks, Kevin. So Tim Harry, Non-Exec Director and Chair of the People Committee. Just very much, I don't want to talk about the detail because you say it's going to get ironed out over time, but I welcome what Sharon just said around the family taking into account what we heard earlier in particular. My only comment is around future assurance from the People Committee to the board, because we had the first look at this format at the last People Committee. And my comment, which I think colleagues on the committee agree, was that it really merits some real quality time on it. So what we're going to weave in to future People Committee is a workshop type review of the BAF, so we can really spend some quality and quantity of time to start to nail out some of that sort of detail, and hopefully that will give some future assurance to the board. Thank you.
Thanks, Tim. That sounds really useful. Thank you. Amy.
Thank you. So I'm Amy Beaton, Director of People. Echoed Tim's comments on we'll spend some more time in the People Committee, but just wanted to highlight we've separated out now the equality, diversity and inclusion risk into a separate risk and not under just under people. So whilst at the moment the lead committee is People Committee for this risk, discussions with Jenna and discussions that will take place in private board is around that BAF risk being discussed in wider committees, particularly Quality Committee. So it's just to highlight that point. Thank you.
Thanks, Amy. Ian.
Hi, Ian Orrell, Non-Exec Director and also Chair of the Audit Panel. Just to say, it's clearly good to see the document, taking shape in the way it is, and I'm encouraged by a lot of the comments that have been made as well. I just wanted to add really that clearly this will form part of the Audit Committee's work ongoing, so that should hopefully strengthen things further, and also just to add that at some stage in the not too distant future we'll have an external review of this by the internal auditors, so that again should assist things. Thank you.
Thanks, Ian. Some conclusions, Jenna. Thank you very much. Thank you for the revised approach, which is, as I've said a couple of times already, a huge improvement, so really grateful for that. I think the approach is well received by board, and it's reflects where we want to be. I think it's worth recognising, it's true to say, isn't it, that this is this is the first run out for this for the BAF in this format, so I'm not surprised that there are a few wrinkles around the edges, but once we get this properly embedded in the committee structure, it'll start to work through those teething troubles, and we'll get the detail and the mitigations and all the rest of it right. So let take that into consideration as part of this. So I think that it's the right approach, it's covering the right things, it's doing it in a way that board clearly finds it much easier to digest and work with, and as it becomes embedded in our committee processes, it will really start to take life. So thank you. Good. Let's move on then to highlight an exceptions report from the Quality Committee. Di.
Thanks, Kevin. So Di Bailey, non-exec and chair of Quality Committee. So just in terms of the paper, there's three things, Kevin, that I just want to just say a little bit more about, really. One is around the quality improvement priority work that the committee has undertaken, and we've got 5 quality improvement priorities, and at the meeting in August we had a really good update about the work that's been going on around carer involvement and physical healthcare. In the light of Sarah's report this morning and the new suicide prevention strategy, I just wanted to flag that the next quality improvement priority that we're looking at, which will be the focus of the November meeting, is actually suicide prevention. So that's really timely, and I think you know, shows that we're on the pace with that one, really. One of the things that was different at Quality Committee this time around, notwithstanding the Bath conversation, was that we had some patient feedback in the executive report, and some of that was positive feedback and some of it was not so positive feedback, and that was deliberately chosen to reflect different views. I think that was really important. Quality Committee has been discussing for a while how we get improved patient voice into the meeting. And I think what it did by having the feedback there was it gave us a real insight into what the subcommittee sees, and in particular the organisational learning group, around patient feedback and what, importantly, we do about it when we get it. So I think we took some assurance from that, really, that it helped us understand what was going on at a more operational level. And then finally, I just wanted to say something about the work that was reflected in the committee, where we looked at the impact of vacancies on quality. And I think what we took from that paper was that it gave real assurance at a service level that we understand the complex relationship between vacancies and the impact on quality, and that service managers are really engaged in mitigating those risks in a range of different ways, which we need to acknowledge. So I think the paper really gives us a good starting point with some rich information over which we can overlay some more quantitative data, which we do need, and the next step is to discuss and decide how we get that quantitative data and pull that into the conversation. So those are all the issues I just wanted to highlight. Thank you.
Thanks, Di. That's really helpful. Any questions or comments for Di? And we're coming back to the issue of the operational impact of vacancies later in private board. Good, thank you very much, Di. Thank you for that. That's really helpful. We'll move on then to item 3.2, learning from deaths report. Girish.
Yeah, thank you, Chair. I was just wondering whether Tim had a question, Chair.
No, it's okay. I'll pick it up outside the meeting. Thanks.
Sorry, Tim.
It's okay.
I apologise. I thought that was on the previous item. Sorry, I didn't spot it coming in.
It was, but I was a bit slow with my
all right.
putting the queue in.
Yeah. Good morning, everyone. I'm Dr. Girish Kunigiri. I'm the medical director for LPFT. This is the Q1 report on learning from deaths to the board. And I thank Helen and the team from the patient safety group in producing this report. This report is produced as a part of the recommendation from the National Quality Board, which says that the issues related to learning from deaths needs to be reported on a regular basis to the board. Just to make the attendees aware that all deaths which happen either in the inpatient or the community are all investigated by our organization. This is for those who are actively involved currently with the services or those who died within the 6 months after discharge from the hospital. All such deaths are initially triaged, and depending on the nature of the death and their intensity, they will be classified into one of the 3 groups, which is called as the serious investigation review or the mortality case review, and the internal critical review, also called as the desktop review, and the leader, which is learning from deaths for people with learning disability and autism. And I'm pleased that all the investigations, particularly those with serious investigations, the family or consultant, and the report also goes to the family. As you see in the report, that the deaths remain generally the same in terms of number also, although every death is very important for us in terms of our learning, both in terms of what is good about LPFT and also what are the areas we need to improve. And they are regularly themed, and these themes are discussed in detail at different levels of our organization, and they are circulated by various means to the teams to have detailed reflection and discussion on a periodic basis. As a result of the investigations and the recommendations, the organization also comes up with a number of quality improvement programs, some of which you would have seen on the reports. And what I need to highlight, which again reflects with regard to the patient story we had this morning, is involving patients and carers in the care plans, and also focusing on physical health for our SMI patients. In summary, the report does assure to the board that we are compliant with our legislative duty. I'm happy to take any questions, Chair. Thank you.
Thank you very much, Girish. It's a detailed and comprehensive report. Thank you. I don't see any comments or questions from colleagues. So we thank you for that, and we'll move on if we may. I think the ball's still with you, as it were, Girish, for item 3.3.
Yeah, thank you. So this is a report on a guardian of safe working, and I thank Dr. Vijay Vaikar, who is the lead for guardian of safe working for the doctors. And this is an annual report, and this is produced to the board on the premise that it is a requirement as per the junior doctor's contract. As you can see in the report, that at any given point of time, we have about 35 junior doctors in the organization. And in terms of the higher specialist trainees, we have about 5, which has increased over time, which is definitely positive, because many of these doctors will continue to work in our organization as consultant psychiatrists. In terms of the junior doctors vacancies, historically we had something to the extent of 60%, but with increase in the numbers, both in terms of recruitment and also in terms of placements, I'm pleased that it has reduced, particularly in the last couple of years, and now it is somewhere around 20 to 30%. And it also depends on the grade, what we are measuring in terms of the number of vacancies. Because of increase in the numbers of the local graduates in junior doctors position, we have gradually reduced the number of international recruitment at this level. We have North and South Rota given our large geographical region. And because of vacancies, we do have some gaps in the on-call rota, but I'm pleased that these are usually filled by our existing junior doctors, and we rarely use locum agencies for that. On an average, we have about 10% of rota gaps, which are filled up by our own doctors. And those doctors who go on these rota, they are adequately remunerated and also provided the adequate rest. We have regular meetings with the junior doctors, and we have regular feedbacks using different mechanisms. And I do attend the Junior Doctors Forum every month, which helps us in terms of looking at the key themes from the feedbacks and putting right mitigations into that. In the last 1 year, we had 3 exception reports where doctors were asked to work longer than the contracted hours. This generally happens when the covering on-call doctor goes off sick and we are informed at the last moments. But all such occasions are satisfactorily compensated by doctors getting the appropriate rest later. There is no financial penalty for breaking any of the safe working directive in our organization. So in summary, the doctors in training are safely rostered and their working hours are compliant with the terms and conditions of their contract service. I'll stop here and happy to take any questions. Thank you, Chair.
Thank you very much, Girish. Any questions or comments on Girish's report? And I say this every time, but they're comprehensive and helpful, and they really do speak for themselves. I don't see any comments, so thank you very much, Girish, for talking us through both of those papers. And we'll move on then to item 4.1, which is the highlight report from the People Committee. Tim.
So thanks, Kevin. Tim Harry, Chair of the People Committee. Just 3 highlights, I think, from the meeting. The first one was that the theme at our last meeting was around training, learning and development, and we heard both from the staff story where there's very positive feedback around the Trust Band 7 learning programme, and together with my sort of personal hearing around the inspirational leadership event around Just Culture, and also the other elements around the learning and development programme. I think we got really good evidence that we have a really good learning and development programme in the organisation, and it's how we use that. That's not to say there aren't challenges, and there were 3 around career progression, release to do training, everybody's busy, and the variation in leadership, but we gained some assurance in terms of the actions to address that. And I think one of the key things around that leadership piece is it shouldn't be around attendance on those around sort of being interested in, which is fine, but there are areas clearly where there is a need for that leadership programme to be applied. The other thing around learning and development was we heard some good assurance around the apprenticeship levy and how well that is working, a really key part of growing our own strategy. And I think from the experience of various members of the committee, it's not true for every organisation that full advantage is taken of the apprenticeship levy. So that was good news. Second point was around the quarterly pulse survey. Again, a low response rate, and as previously reported, we have concerns about the frequency of the surveys. But that said, there was a reaffirmation around the concerning level of responses around harassment and discrimination, and we heard about the actions being taken there around Just Culture, cultural intelligence training, and also discussion, as you inferred earlier, Kevin, around discussion at board level in the private session. The final piece was around the key changes that we made to the fit and proper test with the recently published guidance, and that is in hand and in process to be implemented. So those are the 3 key things. Thank you.
Thanks, Tim. As you say, discussion on ED&I later. The fit and proper person test requires me to do a whole bunch of things, and you'll be getting letters from me. Board members will be getting letters from me at some point in the near future. I think you might already have had one about data. So you know, I'll be sharpening my pencil, ready for writing all of those. That's great. I don't see any other questions or comments from for you, Tim. So thank you very much. And we'll move on then to item 5.1 and the report from the Sustainability Committee. Chris.
Thank you, Kevin. Chris Wright, Non-Executive Director, Chair of the Sustainability Committee. As the committee is titled Sustainability, you won't be surprised that we're particularly focused on the sustainability of LPFT in its broadest sense, but very specific focus on our financial sustainability. This is an organisation which is well run financially, operates within its budget parameters, but there are some pressures. And there are some pressures around agency use, and we're focusing on that. We've also been contributing to the ICB's medium-term financial plan, and we need to submit our information and data in relation to that by earlier this week. And that leads me to talk about the work that's going on with our demand and capacity assessments. And actually, it's very helpful that this next report from Chris Higgins, the Director of Operation, brings some real colour to that work, which is helping us understand what the demand for our services is going to be going forward, and what the capability and capacity requirements for the trusts will be. So I'll leave Chris to give some real colour to that in his subsequent report. We also focused on the business case for the eradication of dormitory scheme at Boston. And we've had a subsequent extraordinary meeting to explore further the emerging business case, and we'll be recommending to the main board that we progress with that. And then with the issues around finance, because it is about sustainability, we also received a report on the Green Plan, and we're going to request a deep dive into what the implications are for the Green Plan and our efforts to manage our carbon footprint, and how that's properly integrated into all of our activity across the trust. So that's all from me. Thank you.
Thanks, Chris. Well, there's a lot in there, some of which, as you say, Chris Higgins will expand on in a moment. It's good to see progress still on the major capital schemes, which are important for the future of the trust. So, that's all very positive. Continued focus of the committee on the longer term sustainability, financial sustainability of our services is welcome too. So thank you for that. Any other questions or comments for Chris? Don't see any. Thank you very much, Chris. So we'll move on to the other Chris Higgins, and item 5.2 in the report of the Director of Operations. Thank you, Chris.
Yep, thanks, Kevin. I'm Chris Higgins, Director of Operations. So just to kind of give you the highlights of this. Firstly, in terms of positive things that happen in trust, first up is the male PQ. We've got a paper on that later on the agenda, so I won't go into that in detail, but we're heading in the right direction. Also linked to that is our work around looking at solutions for providing a local female PQ service. We're doing some work around the feasibility of that, which is going through our Sustainability Committee next week, and hopefully we'll be able to make some progress on that in the weeks and months to come. Other bits just to highlight is that some work that's been done around our service transition, so people who are moving from our children, young people services into adult services, and there's some national publication that's helping support our work in that area. And Amy Butler, who's our head of service for our children's services, is working through a process to develop a new protocol and policy to help guide staff through those transition points. Important to know the focus of the work is around not just age as a defining factor, but that developmental age and flexibility around what best suits for the actual individual patients, which is obviously what the board and the organisation is working towards. As mentioned previously, lots of work going on in the demand and capacity space. There's three kind of key pieces that we've been focusing on. One is activity monitoring, and you'll see there in the report a very colourful chart that we're using to see changes in referral and other activity over time. That doesn't mean one is right or wrong, positive or negative, and indeed what early indications we're seeing, which is positive, we're seeing increases, as you'll see there, in terms of our integrated place-based teams, which is exactly what we want to see, increasing activity in those services, and then looking for corresponding decreases in some of our more specialist services. And so hopefully we'll be able to use that as an effective tool to see and measure impact, as well as seeing emerging trends in terms of demand for services. At the same time, we're doing a piece of demand and capacity modelling using quite a sophisticated piece of software that our business intelligence team have been supporting with, linked in with our business development team. We've used perinatal services as a starting point for that, and that's been complete and proved to be really effective, both in understanding the true capacity of a service to meet demand, be able to adjust that tool according to different levels of capacity in the workforce and different demands that come through. So hopefully we'll be able to use that in a number of different ways. One is to do operational management, so we've got the right capacity in place. The other is we can use it as a planning tool for what we might want to do in terms of developing services. And the third piece being able to demonstrate the efficiency of services, both for ourselves and for our commissioners. And then finally, in that demand and capacity space is a piece of bed modelling work that we've been engaged with from a system perspective. That's been something that's been led by the ICB, covering all types of bed provision, healthcare bed provision in Lincolnshire. For us, it focused on adult and older acute, PQ and rehab beds. And really, you can see the detail in the report, but the main headline is, if we do nothing, population will increase, particularly in that older age group that I think we're all familiar with, and therefore we'll need about 5 extra beds in 5 years' time. What we're going to do is work to see if we can mitigate that by developing community services, which means we might not need those, or indeed whether we need to start to plan for additional beds in years to come. So some of that work we picked up through things like our pilot of the dementia home treatment service and things that we services like that and developments like that we use to manage and develop community services, and we'll just see where we land. But that's the early indication. The only thing I would caveat that with is that that's focused on our kind of current in-county bed provision. What it's not really focused on is things like female PQ, where yes, people have got a bed because they're in an out-of-county placement. It's not ideal, and we may choose to provide things differently locally if we can make that work. But that will rumble on. In terms of challenges, again, I won't go into great detail here, but just a couple of things to know is a number of areas you'll see are challenged particularly from a staffing perspective, and kind of linking into the report that we'll receive in part 2 of the agenda around the impact of vacancies. What we're seeing is those teams, smaller teams, struggle to tolerate vacancies as well as those with a much larger team, which I think is probably obvious in some ways. But what we're seeing is those smaller teams are really struggling in certain areas. So it's working with our people team, and Amy Beattie and I have been looking at how we target our recruitment activity on those areas that have got particular challenges around staffing and what can we do. And we've seen positive impacts of targeted recruitment around things like the PQ and more recently data services, where a focused approach is yielding really positive returns in terms of recruitment activity. The other things just to draw out from here is that the piece around demand for our older people services, particularly that dementia service, which is the first item upon that challenges section. There is a report coming to Sustainability Committee next week that's unapologetically detailed because it is a really complex area that's got multiple moving parts that are all interdependent as to why that is the case. There are plans in place to mitigate that, which we'll hopefully be able to work through over the next coming weeks and months. But as I say, that is more of a demand issue than it is a staffing per se. And the other one I want just to highlight here is Castle Ward. So again, recruitment's better than it has been. We've still got gaps in our workforce in that ward. But it is in a better place from a staffing perspective. The challenges we're facing there are particularly to do with the management of some really complex people on that ward. So people with some really high levels of need and some challenging situations for our staff to manage. And it's that that's causing the pressure rather than necessarily availability of staffing, although that does all interplay. So I'll stop there, but happy to take any questions.
Thanks, Chris. Can I go first with a couple of observations? First of all, it's a really excellent report, well structured, really clear, talks us through the issues, really well, and adds a bit of colour to data that otherwise can cause a bit of indigestion. So really welcome that. Thank you. Second observation is really like the work that you're doing on demand and capacity. Absolutely, I think hits square on what we've been asking for as a board, and to get a better sense of a more concrete grounding to the kind of subjective view that we're being asked to do more, or that demand is increasing. So that's really helpful. I will say, if you're going to present this stuff in this format to the board again, can we find a different way of presenting it? Because for those of us with impaired colour vision, the colourful charts are not massively helpful. That's a personal plea, more than one on behalf of the board. The third point is, it's not surprising to see the kind of consistent theme across services where there are challenges, and we expect it to be around workforce. And Jenna mentioned earlier, it's our biggest risk. A reflection, though, Chris, is that we do have small teams. We do have a number of quite small teams, and they are obviously more vulnerable to staffing issues. But there's something kind of counterintuitive, isn't there, in a large organisation not being able to ensure that small operational teams, have the kind of resilience to work through those kind of short-term problems. And I wonder if there's a more strategic look that we might take around, how we provide, to use the language from the BAF, a kind of first line of, first and second line of defence, to make sure that those smaller teams aren't disproportionately affected by workforce issues. I don't know what the answer to that is, but in a large organisation, we ought to be able to engineer more flexibility around how we deploy workforce to compensate for those issues. That might be a comment that's about telling you how to suck eggs, but I just wonder whether there's something there that we could look at. I've got some questions and comments from others. Sarah.
Yeah, thank you. Just to reiterate, I think it's a really excellent report, and particularly welcome the Sigma methodology around the activity monitoring. So thank you for including that, and a big shout out to the BI team for doing the work around that. I didn't know whether there was any services where the colours were going in the opposite direction, because it focuses on increased demand, but just as a matter of curiosity. So there was just a question there in terms of, are all services sort of going from blue to red? And reading the challenges section, it's quite a sobering read, isn't it, really, in terms of how, in terms of qualified nursing, for example, in the secure unit, how fragile it is. But I'm always fascinated by our bed base in terms of the compared to averages. So sometimes I'm surprised there aren't many people knocking on the door sort of going, can we talk about what you're doing differently? Because it's a stark difference, isn't it, in terms of our bed base, particularly around older adults in a county with an increasingly ageing population. So welcome any thoughts on that one, but it was whether we're seeing any sort of red to blue as opposed to blue to red on any of those services. But excellent report. Thank you, Chris.
Happy to come back on a couple of points there then. So just in terms of that shift of activity, yes, and what I would say, I caveat that this report is in development, and so we're just working through that, but indicating yes, we're seeing shifts in different areas where we would hope to see them. So our integrated CMHTs, our community mental health teams, are seeing a reduction, not everywhere, but in most areas, which is corresponding with that increase in place-based teams, which is reassuring that we're getting that left shift, bending the demand curve, and all the other phrases we like to use around that. But we are seeing an increase in the areas where we hope to, and a reduction in some of our specialist services, which over time should release some of the pressure that are on those services. But we are seeing other things like in healthy minds and things like that, where we're seeing a reduction. Whether it's a sustained reduction, we just need to see. But again, with the introduction of our mental health support teams in schools, you would hope that that's the case. So this hopefully gives us a bit of an evidence base that the initiatives we're taking are impacting in the right places. So yes is the answer to that, but it's we just need to do a bit more work on to firm it up. Absolutely take the point about colours. I'll have a work with our BI team. Have been really helpful in producing this. So about how we present that in a different way. And just in terms of a bit about bed base, absolutely. I think we pride ourselves on the fact of we've really pushed innovation around care closer to home. We've really tried to be creative around how we can support people in their own homes, in their usual place of residence, so that they don't have to be removed from that and care for in an inpatient setting. And you know, not least in our older people services. And what we're seeing is some really positive outcomes from that. That's reflected in the feedback that we're getting through just general feedback in services, and through all the engagement work we've done around piloting our home treatment models. Is people prefer that on the whole. That's been the vast majority of people want to be cared for and know that the risks and complications of moving people, particularly with dementia, into an unfamiliar environment, and what the effect of that can happen. So yeah, absolutely. Always more to do, and I think that's where we just need to test ourselves over the coming years. We can see the number of people growing, particularly in that older adult group, over 65 and certainly over 75 group of the population, is growing significantly. And we just need a sensible and pragmatic view of that. Can we effectively support that growth in demand through community services, or do we need to think about building in additional beds over the next 3 to 6 years? So we've got time to think about that, but we do need to start planning now.
Thanks, Chris. I'm really grateful to you for picking up the colours point. Di.
Thanks, Chris. Di Bailey, non-exec. People have said it already, but excellent report, Chris. I just wanted to just focus a little bit more on the length of stay review, because I obviously feel that this is really important from a quality perspective. And I just noticed there that in terms of the averages, and we're using an average length of stay, and we've got some variation in that. And I just wondered whether some modal data might actually help us as well as averages, so that we understand perhaps what the most common patterning is, rather than just kind of looking at the average. So that was just a comment, really. And in terms of the kind of things that we might look at, am I right to assume that we would look at EDI and protected characteristics as in part of that length of stay sort of analysis, really? And that got me thinking about the great work that the BI team have done here with this, but also what I see at system level in the performance committee. And I think what would be really helpful is some help with some correlational data, so that we can predict where some of our patterning might be going forward, particularly with staffing. And I think that reads across not just in relation to this work, but also in the work that we've been doing, as you know, at Quality Committee, about understanding the impact of staffing on quality. So those were really my points.
Yeah, thank you, Judge. Just to come back briefly, and absolutely in terms of the length of stay work, we just need to get a better understanding of our length of stay, and also a better understanding of what is right for Lincolnshire. So there are the multiple things that affect somebody's length of stay, including how ill they are and our effectiveness of our treatment, but also the resources that are available in the community, the accommodation options. There's lots of different things, but it's getting that more granular breakdown of what are the things that are preventing discharge, or enabling discharge, and being much more clear about that, and what is right for us here in Lincolnshire. And we see variance, not getting to all the detail, but between male and female pathways and things like that, but we need to understand what we're comfortable with and what's right for us. So I'm happy to bring more detail back through the quality governance route.
Thanks, Di. Thank you, Chris. Don't see any other questions for you. I mean, the feedback's really positive, Chris, both on format and content. So thank you very much. Tim's waving at me. Is there any particular reason why you're waving at me, Tim?
Sorry, Kevin. Yeah, I did have a very quick question for
Okay.
Chris, but,
oh yeah, sorry. I didn't scroll down far enough. Apologies.
but it's okay.
I'm not ignoring you. Having ignored you on the last time, I do apologise.
Well, if it happens a third time, Kevin, I definitely will get
yeah, do.
Yeah. Chris, ditto all the previous positive comments on the report. I mean, you set out the challenges in a very clear and it's quite stark, and it's, you know, obviously concerning, etc. And we're all concerned about that. This is a bit of a nerdy question, so apologies for it. But I've heard the phrase fragile services used, obviously, in your report and in other reports as well. Is that actually an official term? Is there a definition, or is it you just using it in a generic way? So behind that is, you know, when I see fragile service, should I feel even more concerned than maybe some of the other areas of challenge?
Yeah, great question, Tim. And I think it's been a subjective assessment, and probably still is at this point in time, where we're concerned, and to the point from an operational perspective, a clinical perspective, that the service is really struggling to deliver where it needs to be. And certainly, you know, from our Sector South team, it is functioning. But it's got one substantive registered member of staff in there, one substantive nurse, and we've got agency staff who are good agency staff who are propping that up, and we're able to do the service. But it's fragile. If the agency staff go off, we won't be able to deliver the service in the way we want to. So but what is happening at the moment is there's a piece of work nationally led by NHS England. Dr. Girish Kunigiri, our medical director, is helping us work through a process of establishing exactly what you're talking about, an objective framework for assessing fragility, because then we can both draw on support from our ICB colleagues and draw on support from NHS England if we've got particular areas that we're concerned about, and learn from other areas in the country as well. So there is a piece of work underway at the moment to set out an objective definition for us all to use.
Thanks, Chris. That's very helpful. Thank you.
Thanks, Tim. Thanks again, Chris. I'm going to suggest that we take a break before moving on to the next item, partly because I've just realised my coffee's gone cold, and cold coffee's not all that pleasant. So it's now 10:43, so let's reconvene at 5 to 11. Thanks very much.
Thank you.
Did you get your authentication sorted out, Di?
I didn't, Tim, and to be honest, it now won't accept my my smart card.
Oh, oh dear. I'm sure it's nothing personal.
Okay, welcome back, everybody. We will we'll press on with the agenda, and we're going next to item 5.3, the integrated performance report. Mark.
Excellent. So thank you very much, Chair. So good morning, everyone. I'm Mark Platts. I'm the Director of Finance, Digital and Estates, and I'm here today to present the integrated performance report. And we're reporting on July's data for this report. So all data triangulates for the same month. I'm going to do an overall summary and then welcome questions, of which my exec colleagues will probably join in and answer on any specifics. So as we've picked up throughout the meeting already, workforce is one of our big challenges, and it is on the board assurance framework as a key area to highlight. However, saying that, we are continuing to recruit well as an organisation. So as of July, we were just over 64 whole-time equivalents above our plan. So that's a really positive step from a people team and a recruitment perspective. However, as you'll pick up in the report, it's really important that we're recruiting to the right roles to help stabilise the staffing levels across all of our teams and pull those through. We had a bit of that in the discussion earlier on during the Director of Operations update report as well. So that's been picked up on. There are a couple of examples in the IPR that I will draw attention to. So on page 11, within the psychiatric clinical decisions unit, that there's reference to incidents that have been raised as a result of staffing skill mixing within that unit as well. So it's really important that we're balancing this recruitment across the right levels to make sure that we've got that right balance of skilled staff across all of our services where possible, really. So another example of where there are challenges around that is within our talking therapies service. So there's a national drive to increase access across that service. That's brought with it a really big drive to increase the number of trainee placements within the service. Now, it's great to bring trainees in because we need to continually future-proof our service, but unfortunately, as a trainee, there are limits around the caseload of patients that they can support and pull through. So we are seeing a slight challenge around our weights increasing and access for the service are below target currently. There are a number of mitigations referenced within the report where we're talking about Dr. Julian, which is a digital solution to help balance that face-to-face support with online digital therapy. However, and I can kind of triangulate this from a recent visit that I've done to a service, there does seem to be an increased patient choice around wanting more face-to-face service delivery rather than the online therapy. So we need to balance that out right and push that forward. But I know Chris has referenced it in previous reports, and there's the deep dive within the talking therapy service within the integrated performance report. So there's a lot going on within that service to help us move forward. So another impact of potentially not getting those recruitment in the right areas where we do need them, we are seeing increased use of bank and agency. So Chris gave a great example across the SET service earlier on, the reliance on that agency to keep that service from potentially being a fragile service. So that's another important area. And from a financial perspective, we are seeing a significant increase in the use of medical agency. So a number of small placements, so not talking big numbers, but a number of small placements around consultants are driving a significant cost increase for the organisation. So from a financial viewpoint, part of the integrated performance report, we do need to balance that out to make sure that we're not over recruiting in potentially the wrong areas, but still having that reliance on bank and agency to keep services going. So that's kind of the triangulated position from the report today. A couple of other highlights from the national metrics. So metric 15, which is around the children and young people's eating disorders. I did want to flag positive movement within the team from that one. So we have gone from an 80% performance to a 90.3% performance in July. So really positive work by the team and continuing to move forward across that one. And likewise, I know we previously talked about, excuse me, our EIP service. So that's another area where performance is increasing from May and previous months. So there is a lot of good work out there. We've just got to make sure that we balance that globally across the organisation. So I'm going to pause there, Chair, if that's okay, and welcome any questions. And I'm sure exec colleagues will come in for any specifics around any items within the report.
Thank you very much, Mark. Di.
Thanks, Mark Bailey, non-exec. It was a comment really more so than a question, I think, because I was with you on that visit to the talking therapy service, and I think what was really clear was patient choice regarding face-to-face appointments, and that we are different to some of our surrounding organisations in that, you know, they are offering posts that deliver it remotely, and I think that is a challenge for us in terms of recruitment. So I think it just goes to show how some of these kind of clinical risks also relate to our workforce risks in terms of how we recruit a workforce to deliver, you know, what patients want rather than you know, what staff might want. So I think that's one challenge for us that we need to heed in terms of going forward. I think the other thing that I was struck by was the frustration within that service of trying to do the right thing by our patients in terms of, because we don't offer a step 4 talking therapy service, their feeling was that a number of people, because they're coming with trauma informed presentations, that they actually need that, but we, you know, there's almost a 3.5, and so I think there's something for us in thinking about that pathway, particularly for you know, women maybe in particular, where we're seeing some of that pressure on some of our inpatient provision. So I think there was some real flags for us, you know, from that service in terms of how we might think about transformation going forward, which would help with the weights, but also I think would support a better patient experience.
Yeah, thanks, Di. Amy.
Yeah, so a comment from me, really. So as Mark highlighted in terms of the recruitment, and we have actually got 265 whole-time equivalents more in our organisation compared to this time last year. I think there's some complexity in around our safer staffing review, and obviously we made that decision around changing the ratios in terms of registered and unregistered. So we have seen a big increase. In fact, we've seen the highest recruitment of nursing in the last couple of months, but because we've also increased our establishment of that registered workforce in line with our safer staffing review, we are still seeing that high number of vacancies, and therefore to reflect that change in that safer staffing and what that's meant to the establishment, particularly in our ward areas, it means that new increase in registered workforce is being filled more by bank and agency. So if we compare to this time last year, we are seeing a lot more registered workforce in the places it needs to be, but because we've upped that establishment of that registered workforce in that safe staffing review, we're still having to rely on bank and agency. Thank you.
Thanks, Amy. Did I get that figure right? Did you say an increase of 265 in the number of full-time equivalents in the trust?
Yes.
In a year. So what's that in terms of a percentage increase in a year? Roughly.
I don't know, Kevin, but I can find out very quickly.
Because it's just worth noting the fact that that's a significant number of staff, and there's a significant cost, and both financial and organisational in taking in that many staff, and it's just worth recognising that point, I think. And the other question is how many of those were filling vacancies in established services, and how many of them were for new investment? I don't mind if you don't have that figure, kind of at your fingertips, as it were. But I think my point about the number is both proportionally and absolutely. That's a significant job of work, bringing that many people into the organisation.
Yeah, thank you.
And not to be underestimated. Sorry.
No, and just to add, in terms of that is circa 45 whole-time equivalent nurses and 72 whole-time equivalent registered professionals. So we've seen the largest increase in our support staff, our additional clinical services of around 125, but we are increasing that registered. And if you look previous years, we just hadn't achieved that increase in registered professionals. Yeah. So I just wanted to contextualise that in terms of there is progress because of that safer staffing review and change in ratio. That's why we're still seeing that reliance on bank and agency.
Yeah, my only point was just that it's an absolutely commendable achievement. So thank you. Mark, anything else from you?
No, nothing from myself, thanks, Chair.
Very good. It's worth noting too that as over the next few months, we'll be moving to a new set of arrangements for gaining assurance on performance with the creation of a dedicated performance committee, and that committee will report into board with a kind of holistic view of performance, so that those processes will change over the coming months. Stay tuned for that, but thank you for that, Mark. That's really helpful. We'll move on then to item 5.4. Chris.
Yeah, thank you, Chair. So yeah, Chris Higgins, Director of Operations. So I am pleased to be presenting this position statement on the male psychiatric intensive care unit. So the board's been very familiar with the fact that we temporarily closed the PQ back about 11 months ago due to critical staffing levels across our adult inpatient wards, and we felt at that time that it wasn't safe to continue to operate all wards, and instead to close one of the wards, which ended up being the PQ because of that was deemed to have the least impact on staff and patients, and to consolidate our staffing onto the remaining wards. And what you'll see from the paper is that that had a positive impact in a number of clinical effectiveness indicators that you'll see set out on page 3, but clearly it also had a negative impact on particularly on those patients who've had to travel out of area far away from home to be able to access their care and treatment. And it's been something we've been committed to as an organisation and as a wider system to rectifying and opening the unit as soon as it's both safe and sustainable to do so. Again, as we committed at the time of the closure, we participated and coordinated quite a large-scale engagement process with multiple people and stakeholders, including staff, service users, the public, and our partners in the health and care system. And from that, we were able to set out a series of conditions that would need to be in place for us to be able to safely and sustainably open the unit. So they are set out on page 3. The clinical effectiveness things are on page 2. So at bottom of page 3 there, you see that they're the things that came from the feedback that people wanted to see us to be able to provide when we reopened the unit. The biggest variable in all this, the biggest factor, which is the one that led to temporary closure, is the number of staffing available to be able to safely run the unit. And so we commenced on quite a large scale recruitment campaign involving our trust people services and the operational teams, service users, and recruitment agency to support us. And I think we've all seen some of the outputs of that, whether that be on the back of buses, advertising jobs at the trust, on petrol pumps, and apparently last night on a high profile football match. We've been out there far and wide trying to get the name and brand of LPFT out there so that people can come and be attracted to work in the organisation. That's yielded some really positive results, and so I suppose the headline of that is we now have about 33 whole-time equivalent staff more than we did at the point of the closure, and because of that and the profiling work that the staff the team have done, we are in a position where we're confident that we can move to phase 1, which was the planned reopening of the unit from next month, initially with just 4 beds, and then with a view to opening the unit in full in March next year. And what we're suggesting, if the board's supportive today, that we move ahead with that plan, and then by March next year, before March next year, we'll bring another position statement about where we're at that point. So 2 things to know, I suppose, in that is, one is that you'll see from some of the figures, and what was just referenced earlier, is we increased our establishment through a safe staffing review that was signed off by the board last year to increase our staffing requirement on shifts, and so the establishment increased across a number of areas. So the relative difference between our vacancy rate from the point of closure to now is probably small, but that's affected by the fact that we increased establishment. But the bottom line is we've got about 33 extra whole-time equivalents in post, which is giving us confidence to reopen. The other point to just mention, because it links to a number of different items on today's agenda and previous, is that at the minute we're relying initially on a couple of agency staff to make that happen. They're known agency staff that we've worked with for a long time. They're people who work regularly on our units and are committed to doing a block booking for us whilst we get other staff in post. But at the moment, all the signs are really positive. Some really effective recruitment work's being done around the PQ, and if we continue as currently expected, we'll have a fully established PQ team before March, so we won't be relying on agency staff at that point. So we're confident we're where we are. The proposal is to reopen as planned next month. When I say next month, just in terms of managing expectations, if we go ahead from board today, that's likely to be the very end of November, but it will still be November. I'll stop there and happy to take any questions.
Thanks, Chris. So just to be clear, the ask of the board is formally to approve phase 2 and the opening of 4 beds in November. Yeah, thanks, Chris. Chris Wright.
Thanks, Kevin. Chris Wright, Non-Executive Director. Chris, thank you for this report and for all the work that's gone into getting us to this point. And I commend you and others for the rigour that's gone into this. This is a very specific and maybe a difficult to answer question, but it relates to the performance report and Mark's observations around the use of agency. And in order to get us up and running, you refer to the fact that we'll be using 2 agency staff on a period of time, and this is why it might be difficult to answer the question. If we know them and they're attracted to the job, why can't we recruit them?
Okay, a fair question. So currently the conditions around agency are more attractive, because whilst they're going to work for the PQ for a number of months, they can then choose to work somewhere else for a number of months. The flexibility about their working patterns are in their own control, whereas if you're a substantive member of staff, obviously that comes a bit more difficult to facilitate. And so I think there's some bits around that. There is work ongoing through the National Bank programme to try to make NHS terms and conditions as favourable as agency staff. At the moment, agency pays more than it does for a substantive member of staff. That's one of the issues that we've got with agency expenditure, and so again, through the National Bank, we're trying to be competitive to be able to attract those people over to work on an NHS contract. But at the moment, pay rates are better, and the flexibility and control or control over flexibility is within the hands of the employee, which seems to be a factor that's playing into this.
Kevin, can I just come back? Because
yes, of course.
Thanks, Chris. And I kind of knew that was the answer. But the reason for asking the question is to challenge us and the NHS more generally about what we need to do to create the flexibility in contracts to attract those kind of people. Because the point is, people are there, they want to do this work, and we've got to find a way of bringing them into our organisation as opposed to working for agencies which, frankly, are extracting funds from the NHS and profiteering.
Thanks, Chris. Girish.
Yeah, thank you, Chair. I'm Dr. Girish Kunigiri, Medical Director. Just wanted to respond to Chris Wright's question in terms of, how do we manage in terms of bringing this flexibility and intensify and providing the right incentive for some of these agency workers to be in our organization, changing to substantive posts. Chris, I just wanted to inform that, when we are doing this exercise, we need to balance how this will impact on the wider staff who are already working as substantive doctors within the organization. Because when we are recruiting someone changing from agency to substantive consultants, and if their demand is not in line with the usual contracts we have with our substantive doctors, then it poses some problems within the organization. And this has been seen in our neighboring organizations, which has resulted in some degree of disquiet and some doctors leaving because there was no parity in terms of not just the remuneration, but also in terms of the working conditions. So it needs to be balanced both ways. Thank you.
Thanks, Girish. Ian.
Thank you, Ian Orrell, Non-Exec Director. Chris, my comment is a little bit similar to the question Chris was asking earlier, but slightly different dynamic. What I was interested in is it's clearly good news that we've been able to rectify the sort of staffing numbers issue, and it's a good level of success there. I'm not sure you can answer this question, but my I suppose issue with it is, are we absolutely sure that the quality of staff that are coming on board now, given we've stretched out I guess further than we have in the past, is at the right level? And I know that part of this will be a test of time, but at the point of recruitment, are we confident that we're likely to say yes to that answer, that question?
Yes is the answer. We've not relaxed our rigorous recruitment processes. People get put through the paces in order to make sure we've got people with the right values, behaviours and skill sets to work on the wards. Also, what I would say in terms of preparation for opening the PQ, where I'm saying towards the end of the month, there's been some states work going off on the unit up until just finishing off now. But we want a period of time for that team, because having been familiar with each other, to come together, to train on the unit, to get familiar with the processes and things on the unit, and the environment, and how they're going to a real team building exercise for 2 or 3 weeks, so that when they're ready to go, they're really a cohesive team who are really prepared to accept patients into the unit. And also, because of the numbers we're dealing with in terms of the patient demand, we've got people currently out of area. We may choose to let them continue and finish their episode of care out of area if that's what they would prefer to do, rather than forcing them back in. And so we'll have a slow build up of patients onto the unit. So again, giving a team time to get to know what's going off, and while patient numbers build up. So absolutely, the level of recruitment and requirements as it always is and always will be for our staff on the wards.
Okay, thank you.
Thanks, Ian. Chris, I thank you very much for the work that's got us to here and for presenting, where we are in the paper with, with real clarity. So thank you for that. Just a reflection on Chris Wright's point. I mean, I suspect that there are always going to be staff, aren't there, that value the flexibility of agency working, and we will probably never persuade them otherwise. But I do think it's incumbent on us as employers to make sure that we're offering the most flexible arrangements that we can, consistent with our imperatives as an organisation, and it might be worth just having a longer term think about that. That's a point directed as much as at Amy as at you, Chris. If there's a premium on people, then we need to make working for LPFT as attractive as possible, and if that means trying to be more flexible than we currently are, then that's probably something we ought to think about. Final point is we need to take a decision, and the proposal is that we'll take the decision, then come to what I suspect are a couple of comments on the point that I've just raised. So we'll take the decision first. So the decision is that the board's asked to approve the proposal to reopen 4 beds on the psychiatric intensive care unit in November. Are people happy with that? I've got a couple of yeses before I even ask the question, which is great. The decision's approved. I'll rewind slightly then and pick up your comment, Chris, and then Amy.
Yeah, thank you, Chair. I think that Amy's comment maybe isn't the same as mine, and I didn't draw it out in my introduction to report, but it's just worth picking up those final section in the main body of the paper about the additional actions that we're considering to make our inpatient services more attractive from a recruitment and retention perspective. We are working up some proposals around them because they don't come without cost, but we know that other organisations pay environmental allowances for staff working in inpatient areas because of the recognition of the impact of working shift work and the impact of working with some of our most complex and challenging environments. And similarly, we're looking at options around the progression of staff from a band 5 to a 6. So that's the main bulk of our registered professional workforce on wards. At the moment, you wait for a vacancy to become available, where there's a suggested approach about whether we could, at the point somebody's deemed competent, they automatically progress to a higher paid banding because they demonstrate competence, but again, won't come without cost. So we are developing proposals around that, but all with the intention of how do we make our wards attractive from a financial perspective, as well as the working conditions that we've got people in.
Thanks, Chris. Amy, did you want to add anything to that?
Yes, thank you. So I was going to highlight those areas, so I won't repeat that. I was also going to highlight that in the integrated care system, in the people arena, flexible working is the top priority for us at the moment, focusing on, and we have engaged with the social enterprise organisation called TimeWise, who has done a diagnostic on our flexible working practices as an organisation, with a number of recommendations on how we can improve and what we need to implement in terms of gaining accreditation with them. And also what I would say is we've piloted recently team rostering. So whilst not necessarily what you would deem as flexible working, we have piloted team rostering in a number of our areas, and one of them is on Ellis Ward, and the metrics that we've seen in reduction of turnover, reduction of sickness has been quite impressive, and so we're looking at rolling that out and giving the teams that ownership themselves around their working practices, and that's had a great evaluation piece. Thank you.
Thanks, Amy. I will say that I'm not at all surprised by that. From my experience in other settings, it's a really powerful tool. So great stuff. Thank you very much. Fabulous. Thank you, Chris. Thank you for presenting that. We'll move on. I think the final substantive item on the agenda, Jenna.
It's just on for information.
Good, thank you. We've noted it. I haven't been notified of any other business. I don't have any other business to raise. Although I can see that Di's typing, so I don't know whether she wants to say something. The problem we're not doing this face to face.
It was just a point of accuracy, Kevin. I'll pick it up with Jenna and Karen. It's fine. Thank you.
Yeah, okay, thanks very much. In that case, then we're done. Thank you very much. That's been a really important and useful meeting. We've taken some particularly important decision around psychiatric intensive care unit and had some good discussions about risk and the kind of pinch points on the trust performance. So thank you everybody for your attention and contribution this morning. We're reconvening to deal with private agenda. I suggest that it's currently 11:25. We start again at 11:45. Pick up some of the business on the private agenda before we break for lunch. So see people again in 20 minutes if that's okay. Thank you very much.